This presentation is a review of venous thrombosis. Venous thromboembolism, or VTE, is the newest core measure. It will be added to the core measure list in 2013. Core measures list the minimum standard of care for frequently seen disease conditions. The core measures are meant to standardize care according to evidence-based practice. The ultimate goal is to reduce the impact of these conditions on the population. VTE now combines deep vein thrombosis, pulmonary embolism, and post-thrombotic syndrome. Deep vein thrombosis, or DVT, can manifest itself as calf pain or tenderness, swelling without or with pitting edema, usually below the knee. It's a distal vein thrombosis, or it can be up to the groin. There's sometimes warmth, sometimes erythema. A pulmonary emboli can manifest itself as a respiratory rate greater than 20, or dyspnea, tachycardia, heart rate greater than 100. There can be cyanosis, hemoptysis. There can be a sudden collapse. Individuals who survive an episode of VTE may have long-term leg pain, lower limb swelling, venous leg ulceration, varicose veins, superficial thrombophlebitis, or venous hypertension. A list of these signs and symptoms can be seen on the lower left-hand corner of the venous thrombosis handout. Expectations of the VTE core measure are listed here. Every patient should be assessed for VTE upon admission and throughout the continuum of care. If there is a need, we have to provide and document VTE prophylaxis, or document why not. If the patient presents with VTE, there must be evidence of 5 days of overlap therapy that may start in the hospital and extend to the patient's self-management after discharge. Discharge teaching becomes key to the patient's self-management of medications and worsening signs and symptoms. To help out with this process, the new core measure checklist is on its way from the printer, and you can see that we've added Assess for VTE under Admission. In the case that we're going to prevent VTE for somebody who's at risk, we would have to document education as far as early ambulation or utilizing segmental compression devices or medications that we might have on board. A list of risk factors for VTE appear on the bottom third of the venous thromboembolism handout. Predisposing factors are those related to lifestyle, and then exposing factors would be those involved like surgery, especially orthopedic, or immobility in the post-op period, trauma certainly, paralysis, cancer is a big one. So take a look at that form to help solidify your understanding of some of the risk factors for venous thromboembolism. The community wellness form has also been updated, and the clip you're seeing is the portion that was added to that form, and that's for every patient, and it just talks about clot prevention. The second page of the core measure checklist has been updated to include a section for patients who actually present with VTE. A discharge teaching sheet for VTE has also been developed, and it's on its way from the printer, and that's to enhance your patient teaching at discharge for the patients who actually have a VTE and have to manage themselves at home with overlap therapy. In summary, the discharge teaching should involve compliance with therapy and the medication, dietary advice, follow-up monitoring, very important when overlap therapy is used for anticoagulation, and then info about potential adverse drug effects. The clinical role then is to be alert for signs and symptoms of DVT and PE. The individual assessment should occur on admission and throughout the hospital stay. And check for appropriate fit for the segmental compression devices and make sure to document when they're on and when they're off. And then monitor for bleeding complications. That's important during anticoagulation therapy. And early mobilization and leg exercises are important. Thank you for taking the time to review this presentation.